to describe the structure of the shoulder joint, to name the muscles acting on the shoulder joint and the rotator cuff or the rotator cuff muscles, explain the range of mobility, to describe the movements of shoulder joint and explain the clinical aspects of the joints. Coming to the shoulder joint, we all know that this is a joint formed by the two bones, that is the scapula and the humerus. Now, the articulation is between the areas that is formed by the glenoid cavity of the scapula and the round head of the humerus. Now, this round head of the humerus is going to articulate in a pear-shaped glenoid cavity of the scapula to form a joint called a shoulder joint. Now, if you look at this shoulder joint, this articular surface is actually covered by a cartilage, that is a hyaline cartilage. We all know this is a synovial type of a joint, and this glenoid cavity is deepened by a presence of a rim, which we call it as a fibrocartilaginous limb or a glenoid labrum. I've already told you that it is a synovial joint and it is of ball and socket variety. That means a wide range of motion is possible at the shoulder joint. Now, coming to the capsules or the ligaments which are present in the shoulder joint, the first capsule which is present here is the fibrous capsule, which is surrounding the whole of the joint, and it is attached medially to the margins of the glenoid cavity just outside the labrum, whereas laterally it will be attached to the anatomical neck of the humerus. The capsule is a thin and lax and allow a wide range of movement. Now, there are different ligaments which are present in the shoulder joint. You can see that there is the different type, like for example, the first one as the fibrous capsule, you can see the coracohumeral ligament, you can see the glenohumeral ligament, and you can see the transverse humeral ligament, which are actually helping in the movement of the shoulder joint. The first one, which we come as the glenohumeral ligament, which are actually the three fibrous bands, or these are three weak bands of the fibrous tissue that are going to strengthen the front of the capsule of the shoulder joint. Then we come to the transverse humeral ligament. This is simply present in the humerus, lying in a transverse direction, and that is why we name it as the transverse humeral ligament. And this also helps in the strengthening of the capsule, and this bridges the gap between the two humeral tuberosities. Then the third one, we call it as the coracohumeral ligament, because this is going to attach with the coracoid process of the scapula and to the humerus, and that is why it is named as the coracohumeral ligament. And this will also help in strengthening the capsule of the shoulder joint, but this is going to lie above, so it will be helping in the strengthening of the capsule from the upward direction, and this will be helping in the stretching, or this will be stretching from the root of the coracoid process to the greater tuberosity of the humerus. Then there is an accessory ligament which we named as the coracoacromial ligament, which actually extends from the coracoid process of the scapula to the acromion process, and this functions to protect the superior aspect of the joint. Then we come to the next feature of the synovial joint, that is the synovial membrane. You can see this is a membrane which is present around the capsule, or this is lining the fibrous capsule, and this will be attached to the margins of the cartilage covering the articular surfaces. If you look at the synovial membrane, this actually forms a tubular sheet around the tendon of the long head of the biceps brachii. This will be extending through the interior wall of the capsule to form the subscapular bursa beneath the subscapular muscle. You can see that this is the extension of the synovial membrane, which is forming the subscapular bursa. If you go to the blood supply of the joint, we can see that there are the different articular branches of the axillary artery, and there are the suprascapular nerve, which are responsible for the blood and the nerve supply of the shoulder joint. Coming to the different movements which are possible at the shoulder joint, we know that this is a synovial joint and this belongs to the ball and socket variety, so there will be a wide range of motion which is possible at this joint. There can be flexion, extension, there can be abduction, adduction, there can be lateral rotation, medial rotation, and there can also be circumduction. Now, coming to the movements, that is the flexion. We know that the normal flexion is about 90 degrees, and it is performed by the different muscles like the interior fibers of the deltoid, the pectoralis major muscle, the biceps brachii muscle, and the coracobrachialis muscle. When we talk about the extension is normal extension is about 45 degrees, and this is also performed by the different muscles like the posterior fibers of the deltoid, the latissimus dorsi muscle, the teres major muscle. Then we come to the next action, that is the abduction. Abduction of the upper limb occurs both at the shoulder joint and between the scapula and the thoracic. Now, this is a very important action because there are different muscles which are involved and they are doing the abduction at different angles. Now, the first muscle, that is the initiation of abduction, that is the start of abduction, is actually occur by a muscle which we call it as the supraspinatus muscle. Now, this supraspinatus muscle initiates the action of adduction from 0 to 18 degrees, and then it is followed by the middle fibers of the deltoid, which continue this action from 19 to 90 degrees of angle. Then we talk about the overhead abduction. Now, the overhead abduction is only possible when the rotation of the scapula occurs, and this rotation of the scapula occurs by the involvement of the two muscles, that is the trapezius with the serratus anterior muscle, which act as the overhead abductor of the arm. So the first one, that is the supraspinatus muscle, this actually initiates the movement of abduction from 0 to 19 degrees, and this also holds the head of the humerus against the glenoid fossa of the scapula. Now, when we talk about this holding of the head of the scapula, this actually allows the deltoid muscle to contract and abduct the humerus at the shoulder joint. Then we talk about the adduction. Normally, the upper limb can be swung by 45 degrees centigrade, 45 degrees according to the front of the chest. This is performed by the pectoralis major muscle, the latissimus dorsi muscle, and the teres major muscle. Plus, there is another muscle, that is the teres minor muscle, which is also going to help in the adduction of the shoulder joint. Then we talk about the lateral rotation. The lateral rotation, normally it is about 40 to 45 degrees, and this is also performed by the different muscles like the infraspinatus muscle, the teres minor, and the posterior fibers of the deltoid, which are responsible for the lateral rotation of the shoulder joint. Then we come to the medial rotation. Now, this medial rotation is normally about 55 degrees of angle, and this is performed by the muscles which are labeled as the Subscapularis muscle, the latissimus dorsi muscle, the teres major, and the interior fibers of the deltoid, which are responsible for the medial rotation of the shoulder joint. The last action, that is the circumduction, which is the combination of the movement, which is a movement which is occurring because of the combination which allows like the flexion, extension, abduction, adduction. So this is the movement in which the distal end of the humerus moves in a circular motion while the proximal end remains stable. And therefore, all the movements combine and follows with the circumduction. Then we come to the relations of shoulder joint. Now, if we talk about the relations of the shoulder joint, posteriorly, if we look at it, we can see that there is an infraspinatus muscle, plus there is a teres minor muscle, which is going to lie posterior to the shoulder joint. When we talk about the superior relation of the shoulder joint, we can see that there is the deltoid muscle plus the coracohumeral ligament, which is going to be present on the superior aspect of the shoulder joint. And we also know that there was an extension of the synovial membrane, that is the subacromial or the subdeltoid bursa, which is also lying superior to the shoulder joint. And definitely in the last, there is a supraspinatus muscle or the tendon, which is also present at the superior or in the superior relation to the shoulder joint. Then we talk about the inferior relation to the shoulder joint. You can see that this is the long head of the tricep muscle, which is lying inferiorly with a nerve that is present, that is the axillary nerve, and a vessel which is lying in a space, that is the posterior circumflex humeral vessel, which are lying inferior to the shoulder joint. Then we talk about the tendon, that is the long head of the bicep brachii, which actually originates from the supraglenoid tubercle of the scapula. And this long head of the biceps is actually intracapsular but extra synovial. This tendon passes through the shoulder joint and emerges beneath the transverse humeral ligament. Inside the joint, if you look at this tendon, this is separated by a separate tubular sheet of the synovial capsule. Now, when we talk about the abduction, this also involves the rotation of the scapula as well as the movement of the shoulder joint. Now, for every 3 degree of abduction of the arm, a 2 degree abduction occurs in the shoulder joint, and a 1 degree abduction occurs by rotation of the scapula. So, this rotation is basically because of the rotation of the scapula and also occurring at the shoulder joint. At about 120 degree of abduction of the arm, the greater tuberosity of the humerus, this actually comes into contact with the acromion process. And if we further elevate the arm, which is accomplished simply by the rotation of the scapula, and that is how the overhead abduction is possible. Now, when we talk about the muscles which are responsible in the scapular humeral mechanism, you can see that these are the different muscles. This is the supraspinatus muscle, the deltoid muscle, the trapezius, and the serratus anterior, which I told you that the supraspinatus is the initiator of the abduction, followed by the deltoid muscle with the assistance of the overhead abduction, with the serratus anterior assisted by the trapezius muscle. When we talk about the stability of the shoulder joint, now this joint is unstable because of the shallowness of the glenoid fossa, the weak ligaments which are present, and its strength almost entirely depends on the strength of the tone of the rotator cuff muscles. The tendons of these muscles are fused to the underlying capsule of the shoulder joint, and the least supported part of the joint lies into the inferior location where it is unprotected by the muscles. Talking about the dislocations of the shoulder joint, this is the most common type of a joint which can be dislocated easily, and this is a large type of a joint, and definitely since the weakest point is the inferior part, so the most common dislocation is on the anterior inferior dislocation, which occurs due to the sudden violence applied to the humerus, where the joint fully abducted pushes the humeral head downwards onto the inferior weak part of the capsule, which tears, and the humeral head comes to lie inferior to the glenoid fossa. Then, if you talk about the subglenoid displacement of the head of the humerus, now this occurs into the quadrangular space, and we know that over here lies the axillary nerve with the posterior circumflexhumeral vessel. So it may lead to the damage of the axillary nerve, and definitely if the axillary nerve is damaged, that means that the deltoid muscle will be damaged, or the paralysis of the deltoid muscle will be there, and there is an area of the loss of the sensation which is present here. Now, this injury is also associated with the injury to the musculocutaneous nerve. So there will be a loss of sensation to the area supplied by the musculocutaneous nerve also. Then since there is a downward displacement, the stretch can also result to an injury or a stretch to the radial nerve, which also leads to the different type of areas injured because of the sensation followed by the radial nerve. When we talk about the rotator cuff tendinitis, which is actually a very painful condition due to the lesions of the rotator cuff muscles, and this is the common cause of the pain of the shoulder joint. And this rotator cuff tendinitis occurs due to the excessive overhead activity of the upper limb, which may be one of the cause of the tendinitis, although this may occur spontaneously. During abduction of the shoulder joint, the supraspinatus is exposed to friction against the acromion process, and you can see that under normal conditions, the amount of friction is reduced to minimum by the presence of a bursa, which we call it as the subacromial bursa, which simply extends between the deltoid and therefore preventing the friction. Now, degenerative changes occurs in the bursa are followed by the degenerative changes in the supraspinatus tendon, and this may extend into the other tendons of the rotator cuff muscle. Clinically, this condition is known as the subacromial bursitis or the supraspinatus tendinitis or pericapsulitis. Now, this is actually characterized by the presence of a spasm of pain in the middle range of abduction, because over here, if you see, the bursa is present, providing the friction, and therefore you can see the smiling face. But when the abduction is done to the minimum area, over here the degenerative changes occurs and the bursa is not present in between, and therefore the patient feel a spasm of pain in the middle range and therefore starts to scream. Whereas when the overhead abduction followed by more of the abduction towards a 90-degree, this bursa again comes in between and therefore the patient is relieved by it, and therefore this is the condition of the bursitis. Now this in this picture you can see that there is the supraspinatus tendon which is actually rupturing, and in advanced cases of the rotator cuff tendinitis, the necrotic supraspinatus tendon can become calcified or ruptured. Then this rupture of the tendon definitely interferes with the normal abduction movement of the shoulder joint, and the main function of the supraspinatus muscle we know is to hold the head of the humerus and the glenoid fossa at the commencement of the abduction. So the patient with a ruptured supraspinatus tendon is unable to initiate the abduction of the arm. However, if the arm is passively assisted for the first 15 degree of abduction, the deltoid can take over and complete the movement to right hand. If we talk about the shoulder pain, the synovial membrane, capsule, and ligaments of the shoulder joint are innervated by axillary nerve and the suprascapular nerve, and definitely the joint is sensitive to pain, pressure, excessive traction, and distension. The muscles surrounding the joint undergo reflex spasm and responsible to pain originating in the joint, which in turn serves to immobilize the joint and thus reduce the pain. Injury to the shoulder joint is followed by pain, the limitation of movement, and muscle atrophy owing to disuse. Thank you.